Hello everybody, my name is Frank. I'm an ER doc and EMS doc in Chattanooga, Tennessee. Wanted to start a video series to provide some quick reviews for EMS providers in the field. I'm talking like less than 10-minute reviews that you can pull up while you're in station after you just got back from a call, or maybe you're thinking about things that might happen and wanted to review real quick and thought it'd be a good idea to throw together some videos of that sort, little quick reviews on various topics. Little bit of background on me. I'm, like I said, an ER doc. I did my residency in emergency medicine, but I also did a fellowship in EMS and am subspecialty board certified in EMS, which is a relatively new thing amongst doctors that we can be subspecialized in EMS. And I caught the EMS bug from being an EMT prior to med school. Worked on a 911 truck for about a year and a half. So that kind of bug stuck with me. I always enjoyed working with EMS and wanted to keep doing so even as a physician. And as you might imagine, I now like helping out the various crews in my area, teaching and other such things in order to improve EMS overall. And so I was trying to think of something else that I could do, talking things over with my wife, who's a paramedic who works in the field. And we came up with this idea for little quick reviews that we could just throw up on YouTube for people, like I said, to review right there in the station after a call, or if you're trying to remember something and are a little bit rusty on it. And now here the idea is. Bear with me as far as I'm not super techie at this point. Could probably have better recording studio, but who knows, maybe we'll get more fancy as we go along. You got to start somewhere. So I decided to do this first one on one of my kind of pet peeve topics, which is A.Fib with RVR, and we'll just go through that one real quick. So we'll start off with a little bit of kind of anatomy, pathophysiology. Okay, now I'm going to subject you to what I think from here on out we're going to refer to as silly drawings, because I'm by no means an artist, but if I need to draw out a concept, this is how we're going to do it. So for A.Fib RVR, what's happening in A.Fib in general is, let's draw a really bad heart with atrium ventricles. So normally your normal beat is going to start in the SA node up here. Let's say SA node. And then you've also got your AV node down here, which its purpose is to delay impulses. What happens in a normal beat is your beat starts in the SA node, spreads down through the atria, makes all the atria contract, and stops at the AV node for a split second before proceeding down through the His-Purkinje system and the ventricular septum, and then getting propagated back up the ventricles from the bottom up. So when it's coming down the septum here, it doesn't cause any sort of beat from that point, and it starts causing ventricular contraction as it's going up. So you get contraction from the bottom up. That's how the ventricles manage to squeeze blood up into the pulmonary artery or the aorta. That's a normal beat. So what's happening in A.Fib is that either the SA node is just not working anymore, or maybe it is working, but you've also got a bunch of little what we call ectopic foci in the atrium, in the atria, that are all also trying to send electrical beats to the AV node. And so when the AV node is working properly, it's doing what it's supposed to do, and it's stopping all of those impulses and delaying them for a little while. And of course the ventricles have to recover from each beat, so there's a period where they aren't ready to accept another beat. What you end up getting is it's got all these beats coming from the various ectopic foci stop at the AV node, and only some of them get to go through. Once they do go through, they still go through this normal process of going down the His-Purkinje system and back up the ventricles. So you get a relatively normal looking QRS. You're just kind of missing the P wave, or it might look kind of funny, and then you have a really irregular rhythm because of all these different foci that are sending off random beats at random intervals. Now what's happening with A.Fib with RVR is just that with the AV node, it could be a little bit diseased, and it's not working quite properly, and it lets more of them through than it should. So since you're getting so many random generations of beat, which so many random electrical impulses from up here, if the AV node doesn't stop all of them like it's supposed to, then more of them are going to make it through, and just because there's so many of them, it's going to be faster than a normal heartbeat. And so you still basically just A.Fib, but it's going too fast because too many of these are making it through. You're still going to have a relatively normal QRS, but too many of them are getting through. That's all A.Fib with RVR is. So here's a good example of an A.Fib EKG, just to run through it again real quick. because I'm sure you all know what these look like. But to review, the basic thing with A.Fib is I wouldn't say necessarily always look for a squiggly baseline, because like this is actually a good example of how the baseline actually sometimes in some leads, like say over here, is relatively flat. The main thing you want to look for is the absence of any recognizable regular P waves. So like you don't see a P wave there, don't see a P wave there, don't really see a P wave there. You might even occasionally see something that you think are P waves, like these guys up here, but there's no obvious pattern of like a single P wave that's before each beat. And then just kind of globally looking at the whole thing, it appears irregular. It's like these two beats are clearly closer together than these two beats, are clearly closer together than those two beats, etc. So it's irregular and there's no obvious P waves. That's your basic definition of A.Fib. And A.Fib with RVR, again, is just A.Fib that's going fast. So before we move into treatment, I want to get into why is this a pet peeve topic for me, and that's because I feel like the term A.Fib with RVR is way overused. Just because somebody has A.Fib doesn't mean they're not also allowed to be tachycardic for any other reason that any of us would be tachycardic. But it seems like anytime somebody with A.Fib is tachycardic, they get labeled as A.Fib with RVR. So the danger there is, as you all well know, you can become tachycardic for lots of reasons, and many of which are compensation for something truly critical, where the heart is trying to keep up cardiac output in a critical situation. And if you go ahead and knock out their heart rate by giving them some sort of medicine to slow them down, in those few situations you could actually end up doing serious harm, maybe even killing the patient. Doesn't happen very often, but I have heard of it happening before. So that's what I want to stress here, is that you need to take the time to think of what's going on here. Is it compensation for something else? The two big ones that I like to keep in my mind personally are make sure they're not in severe septic shock, and make sure I don't think they have a massive PE of some sort. And if kind of those two things check out in my head, then maybe I'll think about slowing them down. But you just need to stop and think for a second about, is this really what I refer to as a primary tachycardia, A.Fib RVR, where the AV node is sick and not and letting too many beats through, or are they compensating for something else and they're tachycardic because they've got a different problem? And if that's the case, then you need to fix that problem, not just slow down their heart rate. But if you do feel like it's a primary tachycardia, what are we going to do? First thing you should do is pretty simple, honestly, which is really just give IV fluids. In any of those situations where it's a compensatory tachycardia, then you're not really going to hurt anything by giving fluids. Even somebody in severe CHF, usually they're a little bit fluid down within their vessels, and they can take, say, a 500 ml bolus and be just fine. And if you give fluids and that improves their heart rate, then great, you might be done from a transport perspective, and we can take it from there once you get to the ER. After that, if you decide that you do need to move forward, again, I'm going to stress stop and think. Is this a compensation for something else? One thing I'd say, again, like I said before, think about severe shock, like a septic shock or a massive PE or something like that. Another thing to pay attention to is the heart rate relatively low. Are we talking about a tachycardia in the 110s or 120s or so? That usually makes me stop for a second and think, is something else going on here? Because a true A.Fib with RVR should really be a lot faster than that, like in the upper 100s, really kind of 160s, 1 to 180s in my mind. But so if we are going to move forward, first off, like all ACLS, are they stable or unstable? And when we say unstable, we mean, are they acutely altered or have chest pain or hypotensive or appear to be in shock? And with all those things, is it because of the tachycardia? Like, don't go, when they're unstable, you're going to end up needing to synchronize cardioversion. But with all those unstable things, is it because of the tachycardia? Because don't go shocking Meemaw from a nursing home who's always demented just because her heart rate's a little bit fast. So try and determine if it's because of the tachycardia or if they're always been like that, particularly with the altered mental status. If you do decide to synchronize cardiovert someone, I'd just go ahead and start at 100 joules on a biphasic monitor, which pretty much everybody has a biphasic monitor. Remember to make it synchronized. Don't defibrillate them. It needs to be synchronized cardioversion. Start at about 100 joules. If you go look at your ACLS card, you'll see that pretty much all the various 4 levels of energy for synchronized cardioversion includes 100, so that's a good place to start. You can always bump up to 150 or even 200 for a second shock if that one doesn't work. If you don't need to cardiovert them, then you can go with the IV rate control, which is what's going to happen most of the time. I'd say the two most common drugs are probably metoprolol and diltiazem. So starting with metoprolol, the dose is about 2.5 to 5 IV, and you can repeat it up to every 5 minutes, up to a total of about 15 milligrams. Or probably even more common than that is diltiazem. The actual recommendations on this say to use weight-based dosing, with the first dose being 0.25 mg per kilogram, which in the average adult is going to be about 20. And then a second dose that you can give one time at 0.35 mg per kilogram. Average dose is going to be 25. I personally start a bit lower than that, again, since I'm constantly worried about, are they compensating for something else? Is something else going on that I've failed to see? I usually start at more like 10, because you can always give more doses at higher if they don't have any bad reaction to it. So I usually start at 10 and maybe go up to 20 after that. And that's basically what you're going to end up doing in the truck. Usually after this, we end up putting them on a diltiazem drip, which may be in your protocols, but I'll leave that to your local medical director about whether y'all are starting drips in the truck or just giving the bolus and bringing them in. Speaking of which, there are some people out there that use esmolol in this situation, but esmolol is one that is extremely short-acting and definitely needs to be put on a drip. So I don't think it's super common in EMS. The services in my area aren't using it because you really have to start them on the drip immediately after you give the bolus for esmolol to work. And then what's the overall goal here is really just to get their heart rate down by about 20%. You don't need to get them down below 100. Just reduce it by about 20% to give their heart at least a little bit of a break. And then we can kind of lower it back to fully normal a little bit more slowly in the hospital, sometimes even over a couple of days after they get admitted. One other thing I'll mention really briefly is you may hear people talk about, in hushed voices, being really scared about A.Fib when a patient also has WPW. As long as you're treating a narrow complex rhythm, you don't really need to worry about that. And as far as when WPW is scary and when you need to avoid giving medicines for it, that's something we'll probably talk about in another video. But as long as you're treating narrow complex rhythm, don't worry about it. Do what we just talked about. And really, that's going to be it for this first rapid review. Again, the goal of these videos is to be something like less than 10 minutes that y'all can just watch real quick and easy in the station. If you like this idea, then let me know in the comments, subscribe, all that good stuff. And please feel free to send, we'll start off with just the comments. I may make an email for this thing later, but feel free to send me in ideas about what topics to cover. Again, the goal being short 10-minute things that we can review real quick. So nothing too complicated as far as suggestions, but anything you think that we could cover real quick in 10 minutes, let me know, and we'll see how this goes moving forward. Thanks all for watching.